Hey, good morning, everyone. Hope you're all doing well today. Hey, let me think here. All right, sorry about that. To make sure my 3-year-old does not make a guest appearance here as we get started. Hopefully, you guys can hear and/or see me, but let me know one way or the other. All right, thank you, Abby. Appreciate it. Now I can be heard out there in the world. I'm not just shouting into the void. Thank you, Dallas. So this week I think we have a neurology quiz which you guys can practice with. So hopefully we'll finish everything up here and then we can maybe move on to the behavioral. So next week or two we'll be kind of catching up. So no worries there. Should be on track, I believe. Of course, if you have questions, post them up on the chat. Post them up. Sticky board anywhere is fine. I think this is where we left off, so if anyone corrects me, that's fine. Pretty sure it's where we finished last time. $19 people in, so that's pretty good. Sure, some of you guys are watching Classroom together, so that's fine too. All right, well, it's 8 o'clock, so let me go ahead and get started here. Anyway, all of your prescription assignments are graded, and I fixed the due date. So I believe, when did I set that to? That's set for the 12th? I might have. So you guys should be able to have plenty of time to review your feedback and kind of go from there. But anyway, I'm going to start recording. And let us continue on with our talk of anti-epileptic drugs. We kind of got through the bulk of the medications that we were going to be talking about last time, and so now kind of wrapping it up in terms of talking about how we're using these drugs and some things to watch out for. So in terms of like levels, so you'll see that is done for several different medications, so like phenytoin, valproic acid, carbamazepine. You don't necessarily need to remember the list of drugs that you get levels for, but why do we do that? Well, one, we can do it for things like efficacy if we're concerned of there being side effects. One of the things I think is important to do is to make sure you wait for the level to get to steady state. And if you recall, it takes about 4 to 5 half-lives for that drug to reach steady state. If you check it too early, the levels are going to look falsely low, and that may lead you to want to try to increase the dose inappropriately, and that can just lead to more toxicity potentially. Again, look out for drug interactions. There are numerous ones, especially as you start to mix and match different anti-epileptic medications. I actually was just dealing with this yesterday. We had a patient who's being admitted after surgery, and so they were on some medications for that, But then also they were continuing a lot of their home medications, which included several anti-epileptics that happened to interact. And so we had to find some creative ways to sort of get around that. But ultimately, if a patient is on a steady dose of their medication, they're not having seizures, they're not having side effects, and the level comes back a little off, whether too high or too low, that's okay, right? You don't necessarily need to do anything. So it kind of goes back to treating the patient and not necessarily the level, right? Anyway, so adverse reactions, you're going to find that CNS, depression is probably going to be the most common thing you're going to run into, although it can range depending on which med you're talking about. So things like Lamictal, lamotrigine, and valproic acid tend to have less drowsiness overall as compared to something like the benzos and the barbiturates, which tend to have sort of the most. And everything is kind of in the middle, in between there. So like for an adult patient who still needs to like go to a job, like something like Lamictal may be a really good option for them versus say an infant who's having a seizure. Well, phenobarb is going to be fine. It's okay if they're not really, an infant may not be getting up and walking around, so it's probably okay that they're on phenobarb for their seizure. So it really just depends on the patient situation. Just be careful with like Keppra or levetiracetam in patients with a history of psychiatric illness, because that can be exacerbated by that. And again, if you have a patient who's on one of these anti-epileptic drugs and all of a sudden they appear depressed, well, maybe it could be related to the medication. So that's something you can try to investigate, right? The dermatologic stuff, this is typically the most life-threatening of issues that you can run into from these anti-epileptic drugs. This includes Stevens-Johnson syndrome, and on that spectrum, even worse than that would be toxic epidermal necrolysis. This is a risk for things like carbamazepine, ethosuximide, phenytoin. I think probably oxcarbazepine and lamotrigine have the strongest warnings about this. And so certainly if you had someone who started to develop like blisters or rash, or say even like the oral mucosa can be affected, they start to develop like sores in the mouth, that could be a big warning sign. You'd want to get those patients to stop taking the med, come in and get evaluated, usually at an ER, like immediately. So especially with Lamictal and Trileptal, like the first signs of anything like that, you definitely want to get them checked out for sure, because it's treatable, but it's got to be done early, because if you wait too long, then patients can succumb to that, unfortunately. In terms of monitoring, you want to try to make sure that they're keeping a diary of how often they're having seizures, so you can look for changes and trends as you change your meds or increase the dose or whatever that you're going to be doing there. Look for adverse effects, because that could be one of the leading reasons why you may need to change meds. Get levels, and then obviously labs are important. So know which ones you need to get CBCs on, because they can cause bone marrow suppression. Know which ones to get sodium on, because they can cause SIADH. Things like that are the kind of things I'd want you to be on the lookout for in terms of like monitoring and test questions and things like that, right? So if I say something like this one causes hepatotoxicity, like you should know which ones to check LFTs for, right? So I think that's probably pretty safe bet from a test question standpoint. I'll have something on that. Anyway, transitioning over into talking about Parkinson's disease. What is Parkinson's? This is basically where you're having sort of a progressive loss of dopaminergic neurons in these patients. And basically, this affects movement primarily. And you can see that they have sort of these four cardinal features. So talk about like tremor at rest. They have rigidity, hypokinesia, and then postural instability. So you can kind of see in this picture here that shuffling gait that these patients have, because it becomes difficult for them to initiate movements. Purposeful movements can be challenging, but they still have tremor at rest. And we'll talk about kind of the etiology of that. But most of the time it's going to be age-related degeneration, just sort of idiopathic Parkinson's, but you can find certain genetic links to this. The drug-induced causes are actually kind of interesting. When we get into the behavioral medicine, we'll talk about how antipsychotics can actually induce a Parkinson's-like state based on the fact that they antagonize dopamine. So instead of losing the neurons, you just block the effects of dopamine. You get the same picture there. Trauma can do this, and even certain chemical exposures can do this as well. So if you had someone who, for instance, was in a house fire and they were exposed to carbon monoxide, that's CO, that could be an issue. Methanol, which is windshield washer fluid. If someone was, say, for instance, an alcoholic and they drank that because they ran out of alcohol, it's something you see more often up in the north where it gets colder and they need windshield washer fluid. So a lot of things can lead to this. But basically, you can find several different dopaminergic tracks within the brain. We're mainly going to be focusing on this nigrostriatal tract, which if you were to look here in this picture, you can see this red projection here. This is mainly what we're talking about, sort of this communication from the thalamus. Actually, I'm sorry, this projection goes up through here. So from the substantia nigra up into the thalamus, which can then help to regulate movement. We'll also see that we'll talk about the mesolimbic pathway as well, which is really important for the dopamine reward pathway. And so that's where we're going to get into talking about like addiction and things like that when we talk about some things in the behavioral section, but we already talked about that a little bit in terms of like ortho, right? In our pain management topic. So basically the brain is pretty complex, and I'm not showing you this picture to try to get you to memorize all of these different interconnections, but what I want to impress upon you is sort of the interplay, the delicate interplay that is maintained when you have normal dopaminergic function, where you can see that different activation of different neurons may cause inhibitory or excitatory signals to be sent out. So for instance, this black projection here is releasing GABA onto this neuron, which inhibits it, right? Because GABA is inhibitory, as we talked about, versus some of these may be stimulatory. So for instance, this one here releases glutamate and causes positive actions here on this neuron, which causes more GABA to be dumped onto the thalamus. Ultimately, though, what we're seeing here is that there's a good balance here between excitatory and inhibitory signals. So that way, when you tell your brain, I guess that's kind of hard to tell your brain something because your brain's telling you to do stuff, but say you want to initiate a movement, that signal is sent through that substantia nigra tract through to the thalamus. There's a good balance there. Oops, I'll mess that up. To the thalamus, and that tells your motor cortex, okay, initiate the movements. Okay, so what happens when you have Parkinson's is you're losing these dopaminergic neurons and you're having an imbalance here. So instead of having a good balance between stimulatory and inhibitory signals, what you see here is there's way too much activity of GABA on the thalamus, which is, we know GABA to be inhibitory, and that causes there to be fewer signals being sent to the motor cortex. So as this progresses and get worse and worse, you become increasingly more difficult to initiate these movements, and that's where you can basically develop catatonia, right? Basically, there's no movements at all. And in fact, there's a good movie called Awakenings, starring Robin Williams and Robert De Niro. I think it was back in the 80s it was made, about the first, provider that figured out you could give levodopa to these patients to replace the dopamine that they are lacking, and you can actually start to get them moving again. So you can look up some trailers of that on Google and get some ideas of what that looks like, but it's a pretty interesting movie. And the other thing that happens too, as you lose dopamine, there's actually a good balance here, a good seesaw sort of pattern between dopamine activity and then acetylcholine activity. As you lose dopamine, you start to develop that rigidity and hypokinesia, but you also get an increase in acetylcholine activity, and this can lead to the tremor at rest that these patients will typically experience. If you can restore that balance by providing more dopamine, then this will balance out and help to deal with that tremor. We'll look at some other means we can try to use to manage that as well. So how is dopamine made and processed in these neurons? Well, basically, you're going to have some precursor amino acids coming in from elsewhere in the body, usually from your diet and other places. But basically, things like phenylalanine can come in here, or you can have things like tyrosine being come in through the diet. And basically, this gets converted over into L-dopa or levodopa. This is sort of the precursor to dopamine. Put a pin on this one because it's going to be really important when talking about our drug therapy in just a little bit. One of the enzymes responsible for metabolizing L-dopa is going to be COMT. Stands for catecholamineO methyltransferase. This is an important enzyme. So notice there's certain points I'm focusing on here. So levodopa is important. COMT is going to be important here. But that levodopa gets converted into dopamine. Dopamine itself can then be packaged up into these vesicles where they can then be released out into the synapse, and they can initiate movement patterns to occur, right? One of the enzymes that's really important for metabolizing dopamine in these nigrostriatal neurons is going to be monoamine oxidase B. This is an important enzyme that's responsible for metabolizing a lot of different catecholamines like dopamine and norepinephrine and serotonin and things like that. But so main things I want you to focus on are L-dopa, it's COMT enzyme, the fact that L-dopa gets converted into dopamine, and that the dopamine gets broken down by monoamine oxidase B. Those are the main points here I want to illustrate in terms of how dopamine and levodopa is processed through here. So Basically, what we're going to see in terms of their features, as we mentioned, is things like hypokinesia, rigidity, things like that. But there can be other things as well that will happen here because they cannot initiate these movements. So things like dysphagia can occur, which may not sound all that bad on its face, but if you think about things like, well, how are these patients going to take medications if they can't even swallow correctly? Maybe they'll aspirate these drugs. They become issues in terms of drug administration on the chronic end of things, as we'll see, and certainly other things like they can have micrographia, hypophonia, things like that related to their inability to initiate sort of the full movements that they're trying to do, basically. But our goals here are to try to minimize and or reverse any functional disabilities patients have, and then hopefully if we can try to like minimize long-term complications, we're going to try to do that. You're going to find that most Parkinson's patients follow a very typical course as they have more progressive loss of those neurons. And so there's only so much our drug therapy can do, as we're going to see here. And at a certain point, a lot of your medications are going to fail, and there's not a whole lot you can do for these patients. So kind of a pretty sad progressive sort of disease, but we'll look at some ways we can help with that. From a non-pharmacologic standpoint, we can see things like exercise and speech therapy are really important for these patients, especially as their dexterity starts to diminish. There's some surgical options here as well. I saw a really cool video just a couple of weeks ago about a relatively young guy, actually, is probably in his late 20s, early 30s, who had a deep brain stimulator implanted, and it showed him with it on and off, and him trying to eat a bowl of cereal, which sounds, as simple as anything for healthy patients. His tremor was so severe that he just couldn't even get the cereal into his mouth. He was shaking so bad. Turned on the deep brain stimulator, and he was able to get it kind of no problem, which is pretty cool. But we'll see pharmacologic therapy is going to be sort of the mainstay for these patients here. And we kind of break it up into either uncomplicated early treatment and then more late stage complicated management of Parkinson's. Here are the list of options that we have for Parkinson's. We have things like our neuroprotective agents. So we'll have our monoamine oxidase B inhibitors and dopamine agonists. And then we'll have some of our symptomatic management, which you can see those two categories come up there again. We'll also have some of our anticholinergics, dopamine agonists, COMT inhibitors, and then dopamine precursors. That's going to be the levodopa that we alluded to before. So in terms of early treatment, if you can try to do things to preserve the neurons as much as possible, that is going to be ideal. And so those are things you want to try to focus on. There's two classes of meds that can potentially help do this, including dopamine agonist, which are going to be basically things that replace replace what the dopamine normally would be doing by just activating the receptors directly. Or we could use a monoamine oxidase B inhibitor, and that will prevent the dopamine from being broken down. So you have more of it sticking around, so more of it can be active, right? And so we're going to see here that both of these modalities can be used to sort of hold off on how long it is before we need to use levodopa therapy, because we'll talk about levodopa extensively. But once patients go on that, they're kind of on that for the rest of their lives, generally speaking, because that's going to be one of the most effective treatments. But kind of once they're on it, they're kind of stuck on it because a lot of your other drugs will tend to lose efficacy, and that's just what they are. So, but the levodopa is going to lose efficacy too over time. So if you can try to hold off on how long it is before you need to use levodopa, that's good. Okay? So if you can hold off on a couple of years before requiring levodopa, that's great. Because again, this is a slowly progressive disease. And it's not like you can do a lab test and tell someone has Parkinson's, right? It's all based on clinical history. So if they don't present with it for a long time, or they maybe don't seek out treatment for a long time, you can see how you can be kind of behind the eight ball here. So talking about first our monoamine oxidase B inhibitors, these are going to include selegiline and then rasagiline. Basically, these are drugs that prevent the breakdown of dopamine, so more of it sticks around for longer. Interestingly enough, selegiline is actually can be metabolized to L-methamphetamine and amphetamine, which is kind of interesting because that will show up on a urine drug screen just like amphetamines normally would, like crystal meth or something like that. Rasagiline does not have that feature there, but it's also probably going to have fewer side effects, but be a little less efficacious because amphetamines themselves, actually, interestingly enough, can cause dopamine release, which is why they're pretty addictive. But in this case here, you can see that it does help out with some of its dopaminergic actions and helping these patients to initiate those movements. In terms of side effects here, you're going to see that things like insomnia, agitation, hallucinations, that makes sense based on some of those amphetamine-like activities. And then orthostatic hypotension is a big issue for most of the drugs we're going to see here. And obviously I can't spell hypotension very well. But you're going to see orthostatic hypotension is going to be a problem for most of these drugs we're going to look at. And that's a problem because these patients are having a hard time moving. They're having this shuffling gait. So if all of a sudden they get dizzy on top of that, it's very easy to see how they could have a fall. They could break a hip. They could, have all kinds of problems that are going to kind of expedite their decline in terms of health and functionality. And so we want to avoid that as best we can, right? So as I mentioned, rasagiline does not have as many side effects. It's probably a little bit better tolerated than selegiline, but probably not going to be quite as effective there. Both of these can present a risk for something called serotonin syndrome, which is going to be something we're going to talk about extensively in our behavioral health section coming up next here. I'll get into that in just a moment, though. So monoamine oxidase B inhibitors can be used as monotherapy sort of in mild cases of Parkinson's disease. And the goal here is that they help to prevent further destruction of the neurons based on some, oxidative stress and things that can occur through the actions of monoamine oxidase B. So hopefully they're going to be giving you more time before the patient requires levodopa. So there's a lot of contraindications here you want to be careful with. So anything that increases dopamine activity, anything that increases activity of things that monoamine oxidase B will metabolize are going to be a problem here. So things that enhance the effects of epinephrine or norepinephrine or serotonin can present some issues here. So things like other sympathomimetics, right? You had a patient who's taking ephedra or pseudoephedrine on top of a monoamine oxidase B inhibitor. That can increase issues in terms of like blood pressure and tachycardia, agitation. If they're taking more broad-acting monoamine oxidase inhibitors, which we'll talk about a little bit in the behavioral section, St. John's wort, certain anesthetics used in surgery, all these can cause interactions here. So you want to be really careful because you can see sort of this risk for having this catecholamine toxicity, including a lot of blood pressure issues, arrhythmias. You can have serotonin syndrome. So that's where I want to talk about some of the dietary restrictions that come about with these meds as well. One of the precursors to a lot of your catecholamines is a product called tyramine. And you'll find that certain foods are high in tyramine and a lot of foods are going to be low in tyramine. You want to have patients avoid foods that are high in tyramine because as they get ingested, a lot of that gets converted into catecholamines like norepi and serotonin and whatnot. If you're preventing the breakdown of those products, you're going to have way too much because you have overproduction and under metabolism, less getting rid of it, so less metabolism of those products. You're going to have way too much of it, and that can lead to things like serotonergic toxicity. I'm going to talk about serotonin syndrome in the next slide set, so don't worry about that so much right now, but can lead to all kinds of side effects. So what are the things that are high in tyramine? I like to think about them, I call them the bougie foods. Like this is foods you would think about that would be present at like a really fancy dinner party with like very hoity-toity rich people. And so these would be things like dried, fermented, or aged meats, or aged cheeses, things like that tend to be higher in tyramine. Things like red wine tend to be higher in tyramine. In terms of like vegetables, like fava beans is a particular one that you don't want these patients to be consuming. I know it was like, when's the last time you had a fava bean? Probably never if I had to guess, but these are things you need to avoid. Or even things like sauerkraut. Maybe you have a German patient and they really like sauerkraut. Who knows? Point is, they should be avoiding these medications here. But there's tons of things they can eat that are not a problem. So most things that are fresh are not going to be an issue there. So they have like roast chicken or barbecued, whatever, that's typically going to be totally fine there as long as it's not like an aged sort of sausage or cheese or something like that. All other vegetables are fine. They can do white wine, beer's fine for the most part. So those are all fine. So it's important just to let them know if they are likely to consume one of those foods, just to avoid them while they're on one of the monoamine oxidase inhibitors. So other things we can do for like early treatment from a symptomatic standpoint is if they're mainly experiencing that tremor, we can basically give them an anticholinergic because the tremor is due to too much acetylcholine because of our lack of dopamine. So if we can give them an anticholinergic, this will help out with that. Problem is you want to be really careful in this with like elderly patients because anticholinergics tend to cause some altered mental status. and so it can cause them to have anxiety, hallucinations, things like that. So you may want to be a little bit more careful. I'll show you an algorithm here in a little bit that'll kind of make that a little bit more clear. With anticholinergics, though, you do want to be careful from a lot of the side effects that can be experienced there. And so this is where we get that mnemonic. And I think I've covered it with you before. But things like, if you ever heard the mnemonic, mad as a hatter, blind as a bat, dry as a bone, hot as Hades, red as a beet. Those are all common anticholinergic side effects you'd expect to see. So when I say dry as a bone, I'm talking about things like decrease saliva production. So you can get dry mouth. You can have urinary retention. You have constipation because everything's kind of slowing down from a parasympathetic standpoint. You can get hot, so the hot as Hades. You can have ultramental status, so the mad as a hatter, all of that. So in those cases there, you can try either reducing the dose or maybe it's just not a good med for that patient. Three main drugs in this category include benztropine, trihexyphenidyl, and then diphenhydramine. I know we've talked about Benadryl before. These other two are new. And so this is good for patients that are relatively young, so like, less than 75, and have just tremor as their main issue. If they're having more hypokinetic sort of issues, then something like a monoamine oxidase B inhibitor or like a dopamine agonist might be better for them. Another med you can use is something called amantadine or Simitrol. This is has a couple of different things that it does here. It has a little bit of anticholinergic activity, has some amphetamine-like activity to help release more dopamine. And can block glutamate at the NMDA receptor. You can see it used in sort of early cases as either monotherapy or maybe in combination with something like a diphenhydramine or something, and can help out reducing some of the dyskinesias and side effects you do get with levodopa, which we'll talk about in a little bit. Do be careful for this in patients with renal dysfunction because they may have a harder time clearing it, lead to side effects, including things like anxiety, insomnia, those anticholinergic activities that we talked about before. So those would be things I'd watch out for. They typically will develop tolerance to these over time. They can be bad, initially. So then it gets into the dopamine agonist. So now we can just replace the dopamine that we're not producing by giving something that just directly activates the receptors. And so these can basically work on D1, D2, D3 agonists. They work on all the dopamine receptors. And we'll broadly categorize these as what we call ergot derivatives and then the non-ergot derivatives. I'll show you what that looks like in just a moment here. But these can be used sort of in place of a monoamine oxidase B inhibitor. So you could have someone who's either on one of these or on something like rasagiline, for instance. You probably wouldn't want to use the two together because you can increase your risk for a lot of those side effects there. And so if you are going to use this with something like levodopa, you do want to reduce the dose of that because, again, you just get too much dopamine activity at that point when they're using the two together. And you'll see a lot of the same side effects as levodopa because they're basically doing the same thing by activating those dopamine receptors. So you can see things like ultramental status. You can see orthostatic hypotension. Here you can also see things like peripheral edema can happen here. There's an interesting one called punding, which is an interesting side effect where it's actually where you're like kind of it's this compulsion to like organize things from like small to large. So they may just like to line up stuff, maybe their coins or toys or whatever that they have there, which is kind of interesting. The ergot derivatives also have the risk for causing this pleuro or retroperitoneal fibrosis and some valve issues. So you may want to be cautious there if patients have a history of valvular disorder or something like that. So the ergot derivatives is really one in this category, and it's called bromocriptine. We'll talk about a few other ergots when we get into migraine management in just a little bit. But we call these ergots because they are derived from the ergot fungus. Here you can see an infected piece of rye that is growing this ergot. And so, again, it's always interesting, I think, to point out the natural, quote-unquote, sources for medications. But this is a case where this used to, infect people that were making bread and other products out of this. They got quite sick, and some of the side effects we'll see here will make some sense. We also have some non-ergot derivatives as well, including things like pramipexole, ropinirole, rotigotine, and then apomorphine. Rotigotine can be good because it's a transdermal product, so it's helpful because they can use it for a couple of days at a time, so it helps with compliance. Just make sure they don't use the same site over and over again, the same exact spot of skin, because it can cause tissue breakdown. And then apomorphine is kind of interesting because it is a derivative of morphine, but it doesn't activate opioid receptors. It just really works to activate dopamine receptors specifically. And this is either used for diagnosis. So if you give this to a patient you suspect has Parkinson's and they have improvement of their symptoms, and that gives you a pretty good clue of what's going on. And it can be given via some alternative routes like sub-Q. So if you had a patient who had really bad dysphagia and they could not swallow anything, this could be a good replacement for that. Okay. So then getting into levodopa and carbidopa specifically, this is like the mainstay of therapy for these patients. So again, you're using things like dopamine agonists, you're using things like your monoamine oxidase B inhibitors in order to hold off on having to use this as long as possible, because once they go on this, they're pretty much on it for forever, for the rest of their lives in a lot of cases. And so if you can try to save this for as long as possible, that's going to be good, because once this loses efficacy, there's really not a whole lot to do for these patients. So it's a combination drug called levodopa and carbidopa, usually called Sinemet. And so basically, normally you could give levodopa by itself, which crosses the blood-brain barrier and gets converted over into dopamine. However, if you were to give it by itself, you'd find that you have peripheral enzymes that will metabolize it and prevent it from getting into the brain. Not great. So you give it along with a drug called carbidopa, and that inhibits peripheral enzymes that metabolize this L-amino acid decarboxylase, is the enzyme there, LAD. It inhibits the peripheral varieties of that enzyme, but carbidopa itself does not cross the blood-brain barrier, so it gives the opportunity for levodopa to cross into the blood, into the brain, and get converted over into dopamine in those dopaminergic neurons. Okay, so it really helps to reduce side effects because you don't have to give nearly as much levodopa, and helps it to act better or act more effectively there. So in terms of kinetics, this is actually really interesting in terms of a drug-food interaction that is unique. Because levodopa is an amino acid, you are trying to, it will compete for the same amino acid sites in your GI tract as things like all the other proteins that you eat. So you can actually find that in some cases, patients may need to move around when they're eating proteins in the day in order to make sure that they are not saturating those transporters and the levodopa can be absorbed effectively. So for instance, I know I was talking to a group of patients with Parkinson's one time, and one of them was like really kind of lamenting. They're really sad because they couldn't eat their eggs in the morning anymore. They really love just their morning eggs. And so they had to move them either later in the day or just not eat them at all, because they needed to take their levodopa right in the morning because they woke up and they're having a lot of hypokinesia issues. So, that's one thing to note is you need to move proteins around. That's the main drug-food interaction you're going to run into here. You'll find, you can see here, that has a relatively short half-life, but by including things like carbidopa, it helps extend that out. And then we can also use another enzyme inhibitor called a COMT inhibitor, or catecholamic O-methyltransferase. Go back to that picture of the neuron, it'll make sense why that works. One that we use is called entacapone, which I'll talk about here in a moment. But we'll see that you can either use levodopa as initial therapy for more severe cases, or if you have maybe contraindications to the other classes of drugs we talked about, or after other treatments have failed, basically. I'll show you an algorithm on how that looks. And basically, this is the most effective treatment for Parkinson's here, and eventually all patients are going to require it, as I said. And the side effects look pretty similar to a lot of the other things we've looked at, like the dopamine agonists, where they can cause dyskinesias, so inappropriate movements, hallucinations, insomnia, orthostatic hypotension, as I mentioned, was a big problem for falls. So those are the things you want to watch out for. So just to give you some ideas of what the dosing kind of looks like, again, you titrate based on the levodopa dose. Typically, you'll hit a cap on your carbidopa at a certain point. It doesn't really get any more effective. And then every couple of days, you'll kind of readjust to see how their symptoms are working or how they're improving there. There's a lot of different forms that are out there. So for instance, there's a controlled release preparation, which allows it to be used, absorbed throughout the day instead of all at once, because it helps out with some of the side effects related to really kind of like peak dose effects there. And then we also have some different dosage forms. So if they had like, dysphagia and they couldn't swallow effectively, well, here we have an oral disintegrating tablet that allows them to absorb it straight from the mouth. So that way they don't have to worry about swallowing it. So that can be effective too. So some people feel like if you start levodopa too early, that it sort of expedites the destruction of those dopaminergic neurons, because the more dopamine being metabolized, the more oxidative stress you put on the neurons. Again, I don't know that we have a clear study that says that's the case, but that's the thought here. So if you can try to hold off on using levodopa as long as possible, that's the best. Instead, you can use things like dopamine agonists and monoamine oxidase B inhibitors in the short term for neuroprotective effects. That way you can hold off on how long it is before you need levodopa. So in order to help enhance the activity of levodopa, we have things like COMT inhibitors. These basically, as I mentioned, inhibit the metabolism of levodopa, so that way there's more of it sticking around to be converted into dopamine. And this is good for patients who may be on sort of maximal doses of levodopa but aren't really getting the full effects anymore. This could be added on to help out with that. Typically, we reduce their levodopa dose at the same time to make sure they're not having too many side effects, and we can titrate back up. In terms of their adverse effects of these drugs, it's mainly just potentiating the effects of levodopa, so more orthostatic hypotension, more hallucinations, things like that potentially. This one does turn entacapone itself does turn the urine kind of brown orange color. So again, that's always something you want to warn patients about anytime you change the color of their excretions, whether it be sweat, pee, poop, anything like that, because that can be a cause for alarm if all of a sudden you have orange urine, right? So as I mentioned, entacapone is the main one you can use with this. This is the main one in clinical use. There's another one that causes a lot of liver issues, so I won't mention it here. And you can even see a triple combination drug of using entacapone, carbidopa, and levodopa to kind of help out with that. So, and typically, what you'll see with progression here is you'll start off on monotherapy for these patients, and as they get more progressive, they'll end up being on multiple medications. So maybe they're on something like amantadine plus levodopa, or they're on levodopa plus rasagiline or something like that. And then eventually you're going to find that once they get on levodopa, they have this honeymoon period where their symptoms get a lot better in terms of like improving. So that way they feel really good, things looking great. But then eventually they will lose effect and they'll probably just be on levodopa, carbidopa at the end by itself because it's really the last thing that's effective for them. So some of the treatment things, if we're finding the drugs wearing off too early, this is usually a result of more progressive loss of those neurons. We can do things like adding entacapone on, so that way that helps make the levodopa work better. You can try adding on a dopamine agonist, or sometimes you may find giving the Cinemet more frequently throughout the day can be helpful for this. As I mentioned, using it as an oral solution can be useful. You can even compound it themselves. We actually add a little bit of vitamin C to help out with stability there, but that way it helps out with the absorption. You can add on a monoamine oxidase B inhibitor. You switch to a controlled release preparation, or in some cases we'll actually either do apomorphine injections, where that actually helps to supplement as a dopamine agonist, or in some cases we'll even do what they call a duodenal levodopa infusions. They can have like a tube placed, they can just have this directly administered to the duodenum, so that way they can have direct absorption throughout the day. You can basically give it as a continuous infusion. So a lot of options there if you find that the drug is wearing off too early. So that's it in terms of question, or in terms of Parkinson's. If you guys have any questions, feel free to post them up. But you guys seem not so talkative today, so I'm just going to continue going on here. But again, if you have any questions, feel free to post them up. The sticky board you can use there. I was on the right board, not the wrong one. But anyway, I'll continue on then, going on with the Alzheimer's. People get more caught up than I expected. Anyway, so with Alzheimer's here, you can see that this is similarly to Parkinson's, a progressive neurodegenerative disease where instead of dopaminergic neurons, we're losing neurons in our hippocampal and cortical, in the cortex, that are going to lead to issues of memory, planning, executive function, and eventual language, identity, all of that. Odalis is saying, how would you know when to take off a patient on combo meds and strictly allow them to use levodopa carbidopa? A lot of times it'll be the case where you're kind of getting to a point. So let's say, for instance, you had someone who was on, say rasagiline by itself for a while, and you started to notice it was losing efficacy. You could either add on levodopa carbidopa at that point, or you could try to maybe just switch over to Cinemet by itself. So you can see how well they're working there. If you start to notice that you're kind of going up and up and up on your doses of levodopa over the course of years, still losing efficacy, that's where you consider adding on something like, a monoamine oxidase B inhibitor or a COMT inhibitor or something like that. Eventually, all those are going to be continuing to lose efficacy, and the side effects are really what's going to guide that. So if they're just having a whole lot of side effects but not a whole lot of efficacy, you may just wean them down and just have them on the levodopa, because again, at a certain point, you're going to get more risk than you are benefits And so you just go with monotherapy, and that's where you can use some alternative administrations like the duodenal administration, as I mentioned, apomorphine sub-Q injections, like sub-Q infusions sometimes are used. So really just depends. But again, it's one of those things where eventually you have the patient die first, or they're just going to have more progressive symptoms, and it gets pretty severe there, as you might find experience in your time. Marissa's saying, so giving carbidopa so that levodopa isn't taken up in your other D receptors, like in your gut. No, so the carbidopa prevents the levodopa from being metabolized in the periphery. So it all gets absorbed into the systemic circulation. But sometimes that levodopa would end up getting metabolized by the LAAD enzyme, that L-amino acid decarboxylase enzyme. By inhibiting that with using carbidopa, it kind of allows levodopa to go through the blood-brain barrier, get up into the CNS where it can do its thing, whereas carbidopa is just keeping that peripheral LAAD busy at the time. So, and you also said, so carbidopa saturates the D receptors in the gut, and that way levodopa can go right to the CNS and activate those dopamine receptors. Not in the gut necessarily, right? So when I was talking about the gut absorption, that was just specifically the amino acid transporters there. So that's why I said there's a protein interaction where if you had someone consume the whole bunch of, like, say chicken or something at the same time they're taking their levodopa, those would compete for the same binding sites, and you'd find that the drug would not be as effective because it just can't get absorbed. But the carbidopa is more for the peripheral actions once everything has been absorbed into that central circulation. Hopefully that makes sense. Yes, thank you for your questions. I appreciate those. Anything else that comes up, I don't mind backtracking, so don't feel like just like you missed the boat on anything. I'll certainly interrupt myself. No problem, right? Anyway, so with Alzheimer's, we're going to see again. This is a progressive disease. You can see some of the kind of changes, the histological changes that occur, where they end up having some of these generation of neurons that causes these plaques to form, where you end up having more immune cells coming in to attack this. You get further degeneration from all the inflammation. So again, it's not a great thing to treat, because again, we don't have really all that effective treatment. There's nothing we can really do to slow or reverse the disease. We can really just treat the symptoms, unfortunately. So hopefully that'll change in the future, but kind of where we're at currently. Basically what we're going to see here is there's a couple of different theories here. There's either going to be this thought of trying to replace the acetylcholine that they're not releasing anymore, or we're going to try to deal with the excitotoxicity, something called glutamate, which we talked about previously, is a major excitatory neurotransmitter, but we'll talk about that in a moment. Anyway, what we do know, at least, is that we're losing these cholinergic neurons, especially in the hippocampus, which is responsible for memory. Normally what happens is that acetylcholine gets released out into the synapse, it interacts with the receptors to cause memory to take place, and then it eventually gets broken down into choline, which is recycled back into the presynaptic neuron, and then to make more acetylcholine, right? So pretty straightforward process here. What you end up finding with, say, someone who has a normally functioning brain, is this is normal transmission, normal activity here. What's going to happen as you lose those neurons is there's just not enough acetylcholine going around to interact with all these different receptors. So what could we do to try and sort of get more acetylcholine? Well, we can give an acetylcholinesterase inhibitor, right? So basically, by blocking cholinesterase, which is the enzyme that metabolizes acetylcholine, you keep more of the acetylcholine around that can interact with these postsynaptic receptors. Okay. So whereas with something like Parkinson's, we gave anticholinergics because we had too much acetylcholine. Here we have too little acetylcholine. What I'm going to do is try to prevent the breakdown of that by giving a cholinesterase inhibitor. So generally speaking, we like to have things with good long half-lives, or at least long durations of action, mainly because these patients have memory impairment. So we don't want them to have a complicated regimen where they have to take, a medication 4 or 5 times a day because they forget. We also want them to have high specificity for the specific CNS enzymes, because if they act peripherally, you will see some side effects, which I'll talk about here in just a moment. And then again, we want them to be able to get into the CNS, do their thing. We'll talk about the idea of reversibility here in just a second. That has more to do with the duration of action of the drug. The toxicities you can see here are going to be cholinergic side effects, because again, we can have too much acetylcholine activity in the peripheral, and so we'll talk about those side effects. So whereas with the anticholinergic actions, we saw blind as a bat, mad as a hatter, all of that. And if you need me to repeat that, that's fine. I'll go through that again. Instead, we have the opposite. Now we have too much acetylcholine activity, and this is going to be the dumbbells, as I call it. So this stands for defecation. urination, because this is stimulating the GI tract, it's stimulating the parasympathetic nervous system, so you're going to see things like incontinence. You see meiosis, so you see the pupils will constrict. You'll have what I call the killer bees, which is not usually a big problem. This is more so if you were to see like a toxic exposure to like, nerve agents or something. But bronchorrhea, bronchospasm, and bradycardia, those are risks there. You'll see emesis, lacrimation, and salivation. So you're getting a lot of fluids, you're getting diarrhea, you can see maybe heart rate drop. These are all things you'd expect to see from having too much acetylcholine activity, which is a risk, not a huge one, but a risk you can see with these drugs here. So the ones we're using, cholinesterase inhibitors, are essentially acting and are good to treat sort of the more mild to moderate cases of Alzheimer's. They help to improve memory, but again, they don't do anything with the overall course of the disease. You're still going to find that continuous progressive neurodegeneration. And so, again, not a whole lot we can do from that standpoint. We have a couple here. I'm not going to talk about Tacrin because we don't really like it because of its high amount of hepatotoxicity and side effects. Don't worry about that one so much. We will talk about donepezil, rivastigmine, and galantamine here more specifically. Again, you can notice here the differences are mainly going to be on things like their plasma half-life, their, how often you have to dose it, things like that. So we'll look at some of the features there. First one we have here is donepezil or Aricept. This one here is going to be relatively specific for acetylcholinesterase, which is good. You don't want it to be affecting a lot of peripheral enzymes. And you see here with the half-life of 70 hours, good because it only requires once daily dosing, which is good from a compliance standpoint. You'll see here that they have pretty mild peripheral or mild peripheral cholinergic effects, so that can be handy. You're not going to see a lot of diarrhea and urination, things like that. However, if someone had a pre-existing, history of incontinence, this may worsen that to some degree. And you may find that because it's relatively reversible from the enzyme, it may have kind of a reduced response in the long term. Although I don't know we have any head-to-head trials to really show that that's going to be a problem there. Be aware that it is metabolized through CYP2D6 and through A4, so you do want to be watchful if they're on any drugs that interact and maybe inhibit those enzymes. So sort of antifungals and things like that, macrolides or something could affect the metabolism and lead to more side effects, right? Rivastigmine is another one that, even though it looks like it has a really short half-life, you think you'd have to be giving it several times a day. It actually has a really strong bond with the cholinesterase, and so its duration of action is much longer. So the half-life here, from a dissociation standpoint, is about 9 hours. So it's actually a twice daily dosing here. This one here, you're going to find no drug interactions because it's not hepatically metabolized, so no kinetic interactions, I should say, which is handy if they're on a bunch of other medications, which, again, it's rare that, Alzheimer's is their only problem. They usually have a lot of other things going on, too, that you'd want to be watching. They're probably taking medications for. This one has kind of slow reversibility, so it's good because it provides kind of more sustained inhibition in the long term. Then we have galantamine. This one's very specific for the acetylcholinesterase and the CNS. Still requires twice daily dosing, so not as good from a compliance standpoint there. And again, you're going to see this is also metabolized through CYP2D6 and 3A4, right? But again, if you're trying to pick between the different ones, I can say, okay, well, the patient only wants to take it one time a day, then something like, donepezil is probably going to be the best option there, versus if I said, okay, the patient's on a CYP3A4 inhibitor, well, then something like rivastigmine is probably going to be better from that standpoint. So those are little things like you kind of want to key in on looking at the differences between these drugs here. Of course, that only really treats the symptoms of Alzheimer's. What about the actual toxicity happening here? There's sort of a theory that by having too much glutamate activity, it causes neurotoxicity, meaning having too much stimulation can lead to oxidative stress and damage done to the neurons, and this is thought to be done through the activities of glutamate. And so it's thought that having too much glutamate activity leads to some of the worsened effects of cognition and memory in these patients here. What we can do instead is to try to block that. So by blocking glutamate at the NMDA receptors, you can help to decrease a lot of that excitotoxicity. We have one drug here called memantine or Namenda. This is better for more like moderate to severe cases of Alzheimer's. We don't have any studies necessary to say that it slows down the progression, but that's kind of a theory that it could help with that. And will help with things like daily activities. You can make sure they can remember to get up and go take a shower or do those independent activities. Because frequently what you're going to find is a lot of the sort of decline for these patients is when they can't perform those daily activities. They can't go to the bathroom by themselves. They can't take care of themselves. And that's usually what ends up with them going into assisted living facilities and things like that. And that is, again, not a great place for them to be because, you know, you can find they're in a new environment. So that really kind of throws them off from their Alzheimer's perspective. They're around more resistant bacteria. You know, so if you can try to hold off on that, that's going to be really beneficial by your patients there. So here's what this would look like. If you have like a glutaminergic neuron releasing glutamate here onto the NMDA receptor, that allows calcium to come in. Calcium is very stimulatory. It leads to oxidative stress and eventual apoptosis of those neurons. The thought is by giving memantine, you can block that and prevent more stress to the neuron and keep it around for longer. So it can release more acetylcholine and do all that good stuff. So you can see here has a pretty long half-life, which is great from a dosing perspective here, and pretty minimal side effects in terms of, you know, maybe a little bit of headache or dizziness, but not a lot other than that, and very few drug interactions. So pretty good drug here. Probably save it if you start to notice your donepezils and rivastigmines are starting to wear off. This may be the next thing you want to move on to. That's pretty much all we have for Alzheimer's. Not a lot else out there currently speaking, unfortunately. So the last section we'll talk about here is going to be on migraines and headache disorders, mainly focusing on migraines. So you can find that you can classify these in several different ways. You know, migraines with aura, without aura, chronic migraines. There's people using too many medications to treat their migraines, which makes their migraines worse, kind of paradoxically. But you'll see that they are mainly treated pretty similar to one another, as we'll see here. But let's focus on migraines first. Why is it that people develop migraines? You know, I don't know if we have the full story on it, but what some of the pathologic sort of issues here happening are basically you're seeing some sort of stimulus that is causing some of the cerebral vessels to dilate. Basically, this dilation of the vessels is going to cause increased pressure on things like the trigeminal nerve. You're going to see this pressure causes a lot of pain, causes these waves of spreading depolarization, and causes further inflammation, further injury here, leading to the pain and photophobia and nausea, vomiting, all the stuff these patients are experiencing during a migraine. So one of the big things we're going to try to focus on is if we can try to decrease that inflammation, if we can try to constrict those cerebral vessels, to relieve that pressure, you're going to relieve a lot of the effects of a migraine, as we'll see here. So that's going to be kind of our best ways to treat that. Now, migraines, I don't know if any of you have experienced them. I have not personally, but they can be certainly debilitating, to say the least. You know, some people are shut down for several days when they have a really severe migraine. Basically, you know, any light, sound, or anything else is just going to be severely affecting them. And so one of the things we want to do is make sure they have reduced number and intensity of migraines. That would be very helpful there. And we're going to see that there's kind of two ways we can do this. We can either do acute treatment for migraines, and there's also going to be some preventative therapies as well. Okay, important to make the distinction between what we're using for acute treatment and what we're using for prevention. And I tell you, I ask this question every single year. I'm asking, you know, what's the best thing on this list of drugs for acute management of a migraine? And they'll pick a preventative drug. Or I'll ask, you know, what's the best one here for prevention? And they'll pick an acute treatment drug. So make sure, just like with everything else we've talked about, asthma, seizures, you know, things like that, try to figure out what's going to be best for acute management and what's better for long-term prevention of the disease. Okay, this is going to be exactly one of those. So we're going to look at some non-pharmacologic therapy, some OTC stuff that you can do kind of more simply, and then what you do when the OTC meds are just not working. So in terms of non-pharmacologic therapy, there's a lot of things that can help out with this. And again, we definitely would recommend this if you can use these effectively. You may not be able to prevent all medication use, but maybe it'll help out. I think one of the biggest things you can do is just to have them take, have a headache diary. That way they can see, okay, well, what were they eating around the time they had a migraine? What were they doing? What were they smelling? You know, all those things can be potential triggers. And so if you can identify those and prevent them from being exposed to those, then you can hopefully prevent a migraine. So that'd be great. You know, things like, you know, sleep and rest, regular exercise can all be helpful as well. But unfortunately, a lot of times medications are going to be required. Common food triggers can be things like alcohol, certainly alcohol after a heavy night of drinking. If you're having a hangover the next day, that can be a big trigger for that. Caffeine, which is funny because you can either have too much caffeine cause a migraine or too little, or having caffeine withdrawal. Like I'm sure most of you are probably having a pretty steady source of caffeine in your diets just to make it through PA school. If you were to cut you off cold turkey, a lot of you probably experience a migraine. But other things like tyramine containing foods, like we talked about a little bit ago, things with MSG in it. Everyone's a little bit different in terms of what their triggers are. And certainly strong smells, flickering lights, loud noises, a lot of different things that can do this. So if you have them, keep a diary, you can identify these issues and try to hopefully have them avoid them. As I mentioned, our pharmacologic therapy can either be acute or preventative. So we'll look at some ways we can try to differentiate between those. And then how we're using them is based on how they're presenting, basically, as we'll see. Generally speaking, we're going to be having patients take these meds as soon as they know they're having a migraine. If they're having an aura beforehand, that's a good trigger to go ahead and help to use these because you can use them before the actual pain starts. However, there's nothing we can do to really treat the aura itself. It's not really harmful, so we're not really going to be able to do too much about that. And typically, we want to limit use to no more than 2 days per week. If we are having symptoms more often than that, we're going to have to find some ways that we can try to prevent those from occurring, and we'll talk about those in just a little bit. So for acute treatments, you can start with the simple stuff. You can start with NSAIDs, simple analgesics, so things like aspirin, ibuprofen, naproxen. Be careful with products like Excedrin because they oftentimes will contain caffeine. So if the patient's having too much caffeine already, they get more of that. That can worsen their headache. So that's one thing to note there. And then oftentimes you'll find acetaminophen is going to be kind of ineffective as just a single agent. From the NSAID standpoint, if they're coming in to see you like at the urgent care or the ER or something like that, Toradol or ketorolac is a really good drug in those settings there because it's parenteral. You can use it IM, IV, and is able to have a stronger anti-inflammatory action than something like naproxen or ibuprofen would. But be careful. Like ask patients when they're coming in to see you with an acute migraine. Ask them what they took prior to coming in because if they just took ibuprofen 800 milligrams right before they came in, you don't want to give them more NSAIDs right then. But if they're like, oh, I took 200 ibuprofen 6 hours ago, yeah, go ahead and give Toradol. You're fine at that point, right? Generally speaking, opioids have no role in treating a migraine unless you absolutely run out of everything else and are having just debilitating pain. Avoid opioids at all costs. They just don't really have any shown evidence for being all that effective for migraine specifically. Oftentimes these patients are also presenting with nausea, vomiting, and so you can try drugs for that, including things like arphenothiazine, so things like promethazine. That's handy because there's a suppository available if they can't take anything orally because of their nausea, vomiting. Things like metoclopramide, prochlorperazine. Be aware of those that they are sedating, which may be okay because if your patient's miserable with a migraine, maybe they just want to go to sleep, but maybe they don't want to be sleepy, so you can have other alternatives. So things like Zofran be perfectly reasonable at that point as well. We'll also find that a lot of your meds for migraine specifically also cause nausea, vomiting, and so that's something you of course would want to be able to pre-treat for as well. So and again, we've already covered these drugs here, so previously we had this later in the semester, so don't worry about that. But again, be aware of what's the difference between a 5-HT3 antagonist versus something like promethazine. Be able to know the differences there, just like we talked about in GI earlier. What are the risk of things like metoclopramide, high doses? Okay, we talked about the dopamine blockade causing Parkinson's like side effects. Those are little things you should still know from when we talked about it in GI, because those still will apply here, right? So in terms of acute treatment, a couple of different things we have here. So we have our ergot derivatives. This kind of goes back to what we were talking about before with the dopamine agonist. But our ergots here are actually strong vasoconstrictors. So another thing you'll see is that you can cause these cerebral vessels to constrict because you're actually activating these serotonin receptors. So the ergots not only affect dopamine, they can also affect serotonin. And specifically, you're activating 1D and 1B receptors. You're activating those receptors and cause vasoconstriction on the cerebral vessels and allow it to relieve that pressure on those nerves up in the CNS. Interestingly enough, the ergots are also a precursor to LSD, which is a hallucinogenic product. And it's also responsible for something called St. Anthony's Fire, which is a sort of a medieval sort of affliction where people thought that they were being afflicted with a curse, usually from the devil or something, where they would actually have the tips of their fingers and toes would feel like they were on fire because of the vasoconstriction they were getting from eating fungus that was infecting the rye when they're making their bread and things like that. So they go on these religious pilgrimages to St. Anthony's Cathedral in order to be rid of the affliction. And they found that as they moved farther and farther away from the infected rye, all of a sudden they got better. They assumed it was due to this, and they called it St. Anthony's fire because again, that vasoconstriction was so severe, it caused a lot of very hot sensations in the tips of your fingers and toes, and could lead to gangrene and amputations and things like that. So anyway, two main drugs we have here include ergotamine and then DHE or dihydroergotamine. So it's pretty easy to tell if something is an ergot. Again, the dosage forms are important because if someone's having acute nausea vomiting, having a nasal spray available is pretty handy, as you'll see there. But again, the main mechanism is they're activating the 5-HT1D and 1B receptors. The other big benefit with the ergots is that they have a long half-life, so they help to decrease recurrence after the acute management. Because you don't want to treat someone for migraine in the ER and they go home a couple hours later to have a migraine come back. And that'll be a problem with some of the other drugs we'll talk about in a little bit. But side effects are really important here. You want to be aware who are contraindicated from receiving these drugs. This is very critical for the use of these. You're going to see if they have, in terms of side effects, you can see things like pain, hypertension, chest tightness. A lot of it has to do with those vasoconstrictive actions of the drugs. They can also lead to ergotism, especially if they have maybe used a dose of an ergot before coming to see you, and then you gave them another one accidentally. And this is related to that peripheral ischemia, that St. Anthony's fire I talked about, where they get kind of numb, painful extremities, paresthesias. And again, rarely you can see things like gangrenous extremities. You can see MI, brain ischemia. Not common, but again, if someone was overusing these meds or if they had another drug interaction, you could potentially see this occur. So that leads to the contraindications. If they have any vascular or coronary disease, I would not use this. If they have unmanaged hypertension, I would not use this. So if they came in and their blood pressure was like 180 over 100, probably not a good option. But if they're like, they come in and they're 118 over 75 with hydrochlorothiazide as their only treatment, yeah, they're probably fine to get it. This is absolutely contraindicated in pregnancy. You do not want to use this as a category X drug, and don't use it in pregnancy because it will constrict all those vessels in the fetus, and they certainly need their blood supply. And then they have impaired renal or hepatic function because this could worsen that as well. So the other big thing is you do not want to use this within 24 hours of your triptan drugs, which is the next category we'll talk about here in just a moment. So the triptans also work to activate the 1D and 1B receptors, but you won't see as many side effects as the ergots. You're not going to see the same contraindications because these are much more clean in terms of their effects. These just affect the 1D and 1B receptors, whereas like the ergots, it can also affect dopamine receptors and other things. So there's a lot of drugs in this category. They're pretty easy to identify because they have triptan in the name. They have sumatriptan, zolmitriptan, rizatriptan, naratriptan, almatriptan, frovatriptan, and then elatriptan. What are the differences? A lot of times it's mainly going to be differences in terms of how long their activity is, which can affect things like recurrence, and then their onset of action. We'll look at more details on that. But the first generation ones really was sumatriptan. That was kind of the gold standard for a long time. And then we had some of our second gen drugs, which are trying to deal with some of the shortcomings of sumatriptan. These had the same exact activity as the ergots in terms of their mechanism for migraine. So they're activating 1D and 1B receptors, cause vasoconstriction that relieves from the pressure and pain and inflammation associated with the trigeminal nerve. These are pretty effective. So we're going to see with things like sumatriptan, which was what we used for a long time because that's the first one we had, is that you do see recurrence being more common than something like the ergots, and then more common than some of our longer acting agents, which we'll see. Typically, though, the agents that have sort of the fastest onset typically have the shortest duration of action, which means they're going to have more likelihood of having recurrence, right? Not happen to everyone, but for some people, they could have that. In terms of side effects, these look pretty similar to the ergots. You can see things like chest tightness, pressure. You're not going to get the same sort of like, gangrenous extremities. That's a much less of a risk here. But you can still see some paresthesias, things like that. In terms of contraindications, again, if they had coronary artery disease, history of cerebrovascular disease, I would not want to use these with those. They have monoamine oxidase inhibitors on board, like they had Parkinson's as well. Had rasagiline on board. I would not want to use a combo because, again, just too much serotonin activity. And then do not use these within 24 hours of ergots. If you were to combine the two, you get way too much vasoconstriction. You could have someone stroke out potentially. You don't want to do that. So how do we choose a triptan? I think sumatriptan is probably gold standard. It's pretty cheap. It's available. Most people are pretty familiar with using it. And it has a relatively fast onset of action. So about 3/4 of people should get relief within about 15 minutes. Obviously, it's faster with an injection than if you're using like a PO or an intranasal form. But again, just take it based on what the patient preferences are. But you do have a decent number of people who are going to have recurrence of symptoms. Not great. So what can we do to get around that? Well, that's where we get into our second gen drugs that help out with that. So some have longer half lives. That way, they get around that sort of recurrence issue that happens there. We'll also see some changes in bioavailability that can affect its use as an oral drug potentially. So let's get into the differences there. So first one here, we have zolmitriptan. This one, nothing really big to differentiate it from sumatriptan here. Again, I'm not going to quiz you specifically on dosage forms, like which ones come as which. Don't worry about that so much. I'd rather you focus on things like, if they have a good bioavailability or a long half-life. So naratriptan is a good example of this, where it has a longer half-life, so it kind of prevents the recurrence, but notice here it has a slower onset. So meaning it may take 4 hours. So that's not going to be ideal if someone's having an acute migraine right now. But if someone has like an aura and they know when a migraine's coming, this may be a good option to help prevent them from having as severe of a migraine in the first place, right? So again, that may be one reason why you might want to use naratriptan versus something with a little bit faster onset. Rizatriptan is one that has pretty fast onset, probably the fastest onset of all the triptans there. However, there's a significant interaction with propranolol, the beta blocker. We'll find that beta blockers are used to prevent migraines in just a little bit. However, this will cause rizatriptan to have decreased metabolism. And so you have to reduce your dose of rizatriptan if you're going to combine this with propranolol. That's one significant interaction that is not really seen with anything else. Excuse me. Next we have almatriptan. This one has pretty good bioavailability here, although note that it is metabolized by CYP3A4. So again, if you have any interacting drugs there, you'd want to be watchful for that. It has a little bit better adverse drug profile than, or drug reaction profile than sumatriptan. So that may be one reason why to try to use this. But again, these are newer, so they might be more expensive. So again, patient may not be able to pay for it due to insurance issues or something. So that's notable. And iprovitryptan is actually notable here because it has the longest half-life, it's about 25 hours. So probably very low risk of having recurrence, but also going to have slow onset. So again, it's a trade-off you're going to be seeing there. So typically for acute treatment, if things like NSAIDs are not working, and again, ask your patients what they've already tried, and they're coming in, that's where we're going to either be using an ergot or one of your triptans for them for acute management. Remember to treat the nausea, vomiting as well. Okay. Typically for like an injectable product like a sub-Q, it's about an hour to kick in for most patients. For PO or intranasal forms, about 2 hours or so. Okay. And most of these patients are going to know what works for them. They're going to come in and say, oh, I usually get a liter of fluids. I get compazine, which is prochlorperazine. I get Benadryl, and I get a dose of sumatriptan, and that works for them. Most people who have chronic migraines are going to know what works for them, so just listen to them. If then it works for them, just go ahead and give it to them. If they come in and say only Dilaudid treats my migraines, then that's another story. I probably wouldn't want to give them that for that purpose there. But anyway, other important things to consider is not to use triptans within 24 hours of other ergots or other triptans because you can see increased vasospasm there. That's why we try to avoid using it more than 2 days per week, hopefully more than 24 hours apart between those doses there. For preventative therapy, you want to think about using this in patients who have like frequent migraines that are disruptive to their daily activities. Maybe they have a contraindication to some of the more acute medications. Patient preference and things like that are reasons to consider using preventative therapy. We have a lot of options here. First of all, and again, think about what the patient's comorbidities are, and that will guide you into picking one of these in many cases. So beta blockers have been thought to be used as first line for a long time, just because they've been around for forever. Propranolol is probably the one that's used most commonly because it does have really good lipophilicity, so it's able to get into the brain very easily. However, any of the other ones will work. So if you had some contraindication, propranolol, you could use something like atenolol just fine. Be aware though that if you use this acutely, if you use like full blast beta blocker right off the bat, you can actually induce a migraine because these are vasodilatory. But the goal here is to try to help prevent sort of that dysregulation and cause some of that dynamism there in those cerebral vessels from getting too the getting more of a constrictive phase versus a dilatory phase. This helps to kind of tamp that down and just kind of keeps the vessels more static and just at one kind of level of sort of relaxation. And so this helps. This is why it helps to prevent those migraines. But if you give it just acutely full blast, it can actually induce a migraine, which is why I want to be careful there. Nowadays, we're starting to see more use of the anticonvulsants, so especially they have like coexisting, behavioral health issues, like bipolar disorder, if they have seizure disorders. This can be useful because it kind of helps to decrease that spreading wave of depression that leads to a lot of that vasodilatory action and pressure on the trigeminal nerves. That can be useful there. Topiramate been used as well. That can be useful basically because it's a pretty good side effect profile for the most part. However, if you have someone who has issues like CNS depression with these drugs, it may not be a good option. Maybe something like a beta blocker would be a better option for them in those cases. Other things we can use include our tricyclic drugs and SSRIs. We're going to be talking about these more so in the behavioral health section coming up, so I'm going to hold off on getting too much into depth with these. SSRIs are not typically used, but if a patient is going to be on that anyway due to depression or anxiety, you can really see if that's going to make it worse or better. That could be something that helps out with that. And this is thought to work by helping to kind of regulate serotonin reuptake and trying to help regulate the constriction and dilation of the cerebral vessels. And then finally, we have the calcium channel blockers, so things like verapamil can be useful here. Again, be careful because if you give them a full blast dose of verapamil, you can cause a migraine to occur. So again, slow and low is generally the mantra here. And then botulinum toxin is an interesting one too, because if you think about it, if a patient's having issues of migraine is related to certain muscles being too constrict or being too taut, especially like in the back of the head, if those muscles then pulling your head back, which can be a source of migraines, you can actually use Botox to paralyze those muscles for a period of time, and will relax that and can help out. So that's usually done on a more case by case sort of basis there. So, as I mentioned, for preventative therapy, start low and go slow. It's a marathon, not a race here. And overall, you're looking to have a decrease in the frequency, duration, intensity of attacks, about 50% or more. So that's where you can consider it be kind of effective. And then kind of reassess every couple of months to see how they're doing from that standpoint. Obviously, you want to avoid any sort of like interfering medication. So again, if you have someone who's on, they're being treated for hypertension and their blood pressure is already, pretty maximally, a pretty good level, adding on a beta blocker may not be great because you could then cause them to bottom out. All right. So little things like that, you want to consider those coexisting conditions when choosing therapy for them. Anyway, so that's it for the neuro section. So I'm pretty much caught up there. I'm going to bring up the next section, which is behavioral health. You guys have any questions at all? I don't see anything. So let's talk about first. Let's talk about major depressive disorder and anxiety. We'll find these tend to kind of go along hand in hand pretty frequently, and we're starting to, I think, as a society, we're getting sort of more cognizant of behavioral health issues, especially depression, anxiety. I think as well, just the world in general these days due to COVID and whatnot. I'm probably going to see a big spike in terms of depression and whatnot if there hasn't already been. We've been treating this probably since the 50s in terms of medication management. A lot of the older class of drugs just tend to be pretty toxic from a side effect profile, which led to a lot of discontinuation of the drugs. It also led these drugs to be very dangerous in terms of overdose, which is something that is a risk for patients who are potentially suicidal with depression, right? You don't want to give them a medication that is very dangerous that they could overdose on and kill themselves with. So nowadays we have a lot safer medications. So as time has gone on, we've gotten more specific drugs that have a much better safety profile. Typically, though, you want your therapy to be addressing both depression and anxiety because they are pretty common bedfellows there. One can often exacerbate the other, which exacerbates the other, and it's a pretty sick cycle there. And in terms of like therapy, it's very difficult to determine sort of like what's most effective because there is a really high placebo effect with treating depression and anxiety because oftentimes mind over matter is really important here because if you think you're doing something good for yourself, even if you're taking a placebo pill and didn't know it, your depression could improve, right? And so there's a really strong placebo effect here. So it's difficult to determine just how effective the meds are and which ones are going to be most effective. And there's not a lot of head-to-head trials, unfortunately. Keep in mind, try to find other things, other causes for their depression, because if you can fix that, it could be a very easy thing to fix, and could, lead to fewer medications being needed for these patients here. Some of these are chronic conditions, though, that are just not going to be able to be helped necessary. But if you can try to maximize, these things that can be beneficial. So, if they have hypothyroidism, well, get their T3 and T4 levels under control, then yeah, then they'll probably help out with their depression. Certain meds, though, can certainly lead to depression. Things like isotretinoin for acne, which we talked about before, a lot of cardiovascular meds, hormonal therapy. So again, always look at the med list, because if you can identify something that's causing the problem, if you can switch them off of that to something else, which may not always be the case, but if you can, that's going to be better than adding on just another medication. And again, this is something that's underdiagnosed, undertreated. A lot of patients who are undertreated may go on to commit suicide, like 10 to 15%. So as a toxicologist, this is kind of like our bread and butter sort of cases that we'd run into of people trying to harm themselves, and with varying degrees of success. And so, yeah, so if we can try to get this treated effectively, and again, get not just with medications, but also cognitive behavioral therapy and other means of helping to treat this is going to be very beneficial. Again, it's not good for job security for me, right? But that's okay. I want my patients to not be sad and try to harm themselves. Anyway, to talk about anxiety, there's a lot of conditions that kind of fall under this umbrella, anywhere from generalized anxiety to very specific things like obsessive compulsive disorder, specific phobias, PTSD, and all of that. And again, normally stress is a good response to some degree. It's a survival response, but you tend to find these patients are sort of having a maladaptive response to stress, and are having way too much of it. That can, again, lead to worsened depression, can lead to a lot of disruption of their normal functioning. Now, why do people get depressed? Why do people get anxious? Well, it probably has to do with some of our levels of basically our neurochemistry is going to be off, right? What the reason for that is, we don't really know, unfortunately. I think for a long time, people thought that it was due to depressed levels of a lot of our monoamines, so things like serotonin, norepinephrine, and dopamine. There's actually a drug that we used to use for blood pressure control called reserpine back in the day that basically depleted your norepinephrine levels. They found about 15% of people that led to depression. So okay, well, it must be because they don't have enough of this of serotonin and norepinephrine. I always hear like serotonin being called like the feel good chemical, but it's interesting because we can give medications that can boost your serotonin levels pretty easily, but they don't fix your depression right away. It takes weeks for that to happen. So there's probably something much more complicated going on downstream. Probably something to do with things like gene transcription, growth factors changing, things like that. So we don't really know why it works. We just know that they do work. Right. So our goals for these patients here are try to reduce their symptoms of acute depression, try to deal with their anxieties, get them back to normal level of functioning so they can get up, get out of bed, do the things they want to do, go to work, hug their loved ones, whatever the case may be, and then hopefully prevent future episodes of depression. So getting into the meds, again, we're going to focus on that here. You're going to see that it's very difficult to determine who is going to respond well to these drugs, because you can find like 30 to 40% of people just respond to placebo alone. If you just gave them a sugar pill and told them, hey, this is an antidepressant, about a third of them are going to get better on their own, right? Because of that strong placebo effect. So how we choose what patients or which meds we're going to use for specific patients oftentimes is based on history. So what did they try before? What's worked? What hasn't? What current medical illnesses do they have? What's the cost of the drug therapy? Are there drug interactions we're going to be introducing here? Adverse reaction profiles, all of that, right? Oftentimes when patients stop taking their antidepressants, it's not because they're not working, it's because of the side effect profile. So again, picking a medication is going to be most suitable for your patient can be the big challenge here. It takes about 2 to 4 weeks to really see full effects. However, side effects happen pretty much immediately. So it's important to educate them, to let them know that, hey, listen, these may not kick in immediately. You may need to give it a couple of weeks. Even though you're having side effects, you may think, okay, well, this isn't doing anything for me, I'm just going to stop taking it. Have them stick with it, right? It may be difficult because compliance is going to be a challenge for these patients here. And you may have a failure rate of about a third of people failing their first therapy there. And so it could be due to the fact they're just more resistant to it for whatever reason. They may not respond to that particular drug well, or they haven't given it enough time or duration or enough dosage to actually get the full effects. Non-compliance is going to be a big reason for this, because a lot of these depressed patients, when they're talking to you, you may ask them, hey, are you taking your medications like you're supposed to? And they probably don't want to get, the look of disappointment from you if you tell them, no, I'm not taking my meds like I'm supposed to. I'm not taking it because of X, Y, and Z. They're probably just going to say, yeah, I'm taking it like I'm supposed to. And then you're like, okay, well, the drug doesn't work, so let's try something else. When really, they're non-compliant. It's not everybody, but you can see how a patient may not want to, disappoint their providers or get that stern talking to. And so, they may lie to you, and it's a shocker to most of you that your patients may lie to you at some point in your career, but it may happen more than once, perhaps. We have different classes of antidepressants here. So starting out with the oldest ones down to the newer ones, we tend to find that the older ones were less selective for their specific actions, and so you see a lot more side effects. I'm not going to talk about the monoamine oxidase inhibitors too much here, because you really don't find that many patients being treated for it or with those drugs anymore, because they just have really bad side effect profiles. Nowadays, though, we have more selective agents. They tend to have better side effect profiles. They're also much less dangerous in overdose, which is good, because you may find some number of people on these antidepressants will try to harm themselves with these drugs, and you don't want to give them a loaded gun, so to speak, right? So we'll talk about tricyclic drugs. We'll talk about SSRIs and then our SNRIs in terms of how they're working there. In general, though, most of them are enhancing the activities of norepinephrine and or serotonin. Again, what the full mechanism is, we're not really sure there, right? Probably some sort of downstream regulatory changes that happen, but we just don't have a full unified theory on why these actually work in the long term. So again, I'm not going to talk about the MAOIs too much, because again, they just don't get used that often. And we kind of talked about some of the issues that we run into when we talked about the monoamine oxidase B inhibitors with Parkinson's. The ones that you'd see used for depression are non-specific, meaning they affect monoamine oxidase A and B. So you'd see even more drug interactions in terms of like the tyramine stuff. But basically, don't mix and match MAOIs with any other class of antidepressants, and really just don't mix any class of antidepressants. Really want them to be just on one med at a time for this kind of stuff here. But anyway, let's talk about TCAs, because you will see quite a fair bit of TCAs being used here. And these are actually derived from the phenothiazines, which are the antipsychotic drugs that we're going to talk about probably next week, if I had to guess. Basically, what these do, though, is they block reuptake of serotonin and norepinephrine, meaning that instead of recycling, when you release serotonin and norepinephrine into the synapse, instead of recycling that and sucking it back up into that presynaptic neuron, you block that. So more of it's sitting out there in the synaptic junction and is able to interact with those postsynaptic receptors. So you're boosting those levels of the neurotransmitters available to interact with the receptors. Again, that's what they thought. There was low levels of neurotransmitters, so let's give you more neurotransmitters at the site of action. These were used first line for a long time because they were more effective than the MAOIs, had fewer drug-drug interactions, drug-food interactions. However, these are extremely dangerous in overdose, so that's going to be a big problem we're going to see. And again, suicide risk is a big black box warning for almost every class of antidepressant we're going to talk about here. Nowadays, though, you're going to see the TCAs actually being used for more kind of sort of off-label uses. So you may see them being used for neuropathic pain conditions. You also see them being used for insomnia for a lot of things, or in a lot of cases. And in fact, what's interesting is that with Florida, Florida's pretty slow in terms of getting PAs and NPs the ability to write for controlled substances. So oftentimes, if you'd have someone who is having sleep issues and they were seeing a PA or nurse practitioner, the only option was to give them a non-controlled substance for sleep that was sedating, and oftentimes it was a TCA. So that's where I would see a lot of use for this. Nowadays, though, if you have your DA license, you can now prescribe for more specific sleep agents, but most of those are controlled substances, like benzos and things like that. But anyway, the TCAs, ones that fall into this category include amoxapine, amitriptyline, clomipramine, desipramine, doxepin, imipramine, and then nortriptyline. These are the main ones you're going to be running into here. Probably the most common ones I see include amitriptyline, doxepin, and nortriptyline, but really any of these are still in use nowadays. These have a lot of adverse effects, and so the reason is because they don't just affect serotonin and norepinephrine; they affect a lot of other receptors as well. So first off, they're anticholinergic, right? They're blocking muscarinic receptors. So you can see things like that mnemonic we talked about before: mad as a hatter, blind as a bat, hot as a hair, dry as a bone, and red as a beet. You mean to go back over those effects again and what those mean? Just let me know. They also cause tachycardia, which in and of itself is not terrible, but if you include that with the fact that it can cause conduction delays because it blocks sodium channels in the heart, just like some of the antiarrhythmics we talked about before, you can run into some problems. So arrhythmia is a big risk for these, especially in overdose. You can see they block alpha receptors. So they cause hypotension. They can cause sexual dysfunction, which is a big issue for most antidepressants. Cause some weight gain, and they are quite sedating due to their antihistamine actions. So you can see here that, yeah, it may fix your depression, but if you're super sleepy and your blood pressure is low and you're just kind of laying, you may not feel good to get up and move anymore than you were than if you were depressed. So a lot of challenges with this. Also very dangerous and overdose. If you, if, from a toxicologist standpoint, if you tell me someone overdosed on their SSRI, which we'll talk about here in a moment, I'm concerned for the patient, but I'm not that concerned about their mortality. If you tell me someone overdosed on a TCA, I am much more concerned about that. These are very dangerous drugs. And so, again, when you give a depressed patient, these drugs here, you don't want to be giving them something they can use to harm themselves. But for a long time, this is just what we had. This is all we had to use. That was kind of the gold standard. Nowadays, though, we have more specific drugs. So the SSRIs were the first ones that really came about and were much more specific and much safer. So much better safety profile. The reason why they're much safer is because they're very specific in what they do. So they only block the reuptake of serotonin. That's why they're selective serotonin reuptake inhibitors. They block reuptake of serotonin, and then again we have whatever downstream thing happens, and they help treat your depression. They don't affect alpha receptors. They don't affect your muscarinic receptors. They don't affect the sodium channels on your heart. So they lose a lot of those really nasty side effects you see with the TCAs, and very specific. I'd say they're totally safe, but they're much safer, especially in overdose. Main ones you run into here include citalopram, escitalopram, fluoxetine, paroxetine, and then sertraline. These are your main SSRIs you'll see. So as I mentioned, you'll see a lot less issues in terms of antihistamine action, antimuscarinic action, so you lose all the side effects. Typically less weight gain, but the most common stuff you're going to run into includes some GI upset, see some sexual disturbances. So again, that can be a huge reason for people discontinuing the medication if they're having, relationship issues with their partners because they're not able to have sex anymore, either due to decreased libido or anorgasmia or things like that. That can exacerbate their depression, so may lead to early discontinuation. And then headache and insomnia are pretty common too. Interesting enough with these drugs is you don't want people to abruptly discontinue them because you can have a withdrawal phenomenon that occurs. So say if someone's taking for a couple of weeks and they say, this isn't really for me, I'm going to stop taking it. They can end up having these rebound phenomenons of a lot of sleep disturbances and anxiety, which again, if they're using it to treat their anxiety in the first place, it's not going to be great because it's going to get a lot worse for them. And so one way we can try to do this is either to taper them off of their dose. If they know they want to stop taking, we can taper them off slowly. Or if we can use things that have like a longer half-life or with active metabolites, there's primarily fluoxetine. It has a much more natural taper in terms of its levels, so you mitigate some of those withdrawal effects. But sometimes even a single dose being missed causes them to feel really miserable, and hopefully will prompt them to go back and take their dose. So that way they not going to have those withdrawal effects. Now, for the most part, you're going to find that these are good for helping out with anxiety for most patients in the long term. However, for some, you may find that their symptoms are actually worsened. So, again, if it's not working for them, you can try switching to a different agent and see how that does for them at that point. A lot of this is trial and error. There's no guideline that says, yeah, this is the one you want to go with every time. You just got to mix and match and see what's going to work for your patient there. I guess not mix and match, but you can try different ones and see what's going to work best for your patient. Notably, citalopram and escitalopram can cause QT prolongation, so this is more of a problem in overdose, or if you have patients who are taking these meds with other things that prolong the QT. So be very careful if you're mixing, if you're combining, citalopram and escitalopram with something that already on that prolongs QT. You may want to get an EKG to look for that. And then, as I mentioned, black box warnings for a lot of these classes here, but again, you'll see this with the SSRIs as well. Where in the short term, you can actually increase the risk for suicidality. And you're thinking, well, Why would I give someone antidepressant if it's going to cause them to commit suicide? A lot of this is because some patients may have pre-existing thoughts of self-harm, but they don't have like the energy to act on them. Does that make sense? They're just kind of like, oh, would probably the world would be better off without me. I'm going to end it all, but they can't really muster up the energy to do so. One of the things you'll see with these drugs, the first kind of thing you'll get back is a little bit of energy. And so in some cases, they may still have the thoughts of self-harm that have not been treated yet, but have this increased energy to act on those thoughts. So you see this more so in like adolescents and children. So just know that that's a risk. It's not going to happen to everyone, but it can happen. So at least warn patients, let them know, hey, if you start to feel like you want to like actually harm yourself, anything like that, come in the ER, call 911, tell their healthcare, tell other people around them, loved one thing like that. That these are the things they should be watching for, basically. Then after the SSRIs, we have the SNRIs, which are basically blocking norepinephrine and serotonin reuptake. So a little bit like the TCAs, but they have much fewer side effects than the TCAs because they don't have all the antimuscarinic activity, sodium channel blockade, all of that. So in terms of safety profile, I'd probably say the SSRIs are best, followed by the SNRIs, and then followed by the TCAs at that point. You'll see SNRIs used for a lot of other indications as well. So a lot of neuropathic pain is the main thing you'll see here. So TCAs, SNRIs are good for neuropathic pain, and SNRIs, again, a little bit better safety-wise than the TCAs are. You'll see in this category includes venlafaxine, desvenlafaxine, duloxetine, milnacipran, and then levomilnacipran, the main ones you'll run into. You probably have a little bit more GI disturbances in the SSRIs. You can still see sexual dysfunction. And venlafaxine specifically, but I think with some of the other ones as well in this category, due to the norepinephrine effects, you can't see rises in blood pressure. So you would want to be watchful for that. They have pre-existing hypertension that's not really well managed, and SNRI probably is not going to be the best option for them. And then interestingly, duloxetine does have some anticholinergic activity, so you can see some of the side effects here, including dry mouth, constipation, and all of that. So things to watch out for. So totally, and we have a few sort of miscellaneous ones here that don't really fit into any of those other broad categories. First, we have bupropion. This is one that works, instead of on serotonin, works to block reuptake of norepi and dopamine. So this is actually kind of interesting because we're using it for some substance use issues as well, because it can help to re-regulate that dopamine pathway that is thought to be responsible for addiction to substances like nicotine. I think you're starting to see this used for certain binge eating disorders as well as an off-label use, but kind of interesting from that standpoint. In terms of adverse effects, you will see things like tremor, insomnia. A lot of it's related to the norepi and the dopamine effects there. But be careful if anyone has a history of seizure disorder or arrhythmia. Bupropion is probably not going to be the best drug for them because it's going to certainly exacerbate that. Some of the worst seizures I've seen have been bupropion induced in terms of being just really difficult to treat. The other claim to fame for bupropion or Wellbutrin is the fact that it has less sexual dysfunction. So this has, if you have someone who has sexual dysfunction on something like Lexapro, try switching them over to something like Wellbutrin, and chances are you'll probably have a lot less likelihood of having that happen. So that could be a good option. That's why a lot of people do like Wellbutrin, because it's better from that sexual standpoint. So something that all these drugs can potentially cause is something called serotonin syndrome, which I kind of alluded to previously when talking about the MAO-B inhibitors for Parkinson's. This is basically any sort of condition that is coming about from having too much serotonin around. And is oftentimes due to having multiple medications that enhance serotonergic activity. So if I included a monoamine oxidase inhibitor, like selegiline, plus having a bunch of tyramine containing food, or if I mixed a TCA along with an SSRI, right? That's what's going to be increasing the risk here. And so basically the four big things you're going to run into include altered mental status, hyperthermia, autonomic instability. Sorry, that's a weird noise going on my computer here. Autonomic instability, and then increased muscle tone or clonus. So what that means is that when I say autonomic instability, can mean things like hypertension, tachycardia, bradycardia, hypotension, just their cardiovascular system is going to be all over the place. And so the problem with this is that this looks like a lot of other things, like meningitis, for instance. And so it's difficult to determine unless you have a smoking gun that came with the bottles of medication or something like that. So the big things to watch out for is just to make sure they're educated on not mixing and matching these medications here. Know what to avoid if they are on anything that blocks monoamine oxidase, to avoid those tyramine containing foods, because it can be fatal if not caught and managed effectively, especially with that increased clonus, especially in the lower limbs. They can develop things like rhabdomyolysis. They can develop seizures, hyperthermia, so it can be pretty difficult to manage there. So basically what we would do for those patients include making sure they're well hydrated, making sure they have good IV fluids coming in, usually cooled IV fluids. Maybe do like some evaporative cooling. And since the problem is too much serotonin, we can block that with using a drug called cyproheptadine. It's actually an antihistamine drug we talked about previously, but this also has some serotonin blocking effects there. So those are the main ways you treat serotonin syndrome if that did occur. But again, it's usually not the most common thing you're going to run into, but it can happen, especially if you hear that combo of different meds that all help to enhance serotonin. So real briefly here, we have St. John's wort. This is actually this is a dietary supplement you may find patients that can use for more mild cases of depression. Patients asking, how long does serotonin syndrome take to develop, by days or hours? It can depend. I think usually in a lot of cases, if it was like an overdose sort of standpoint, being within a couple of hours. For cases of where it's more of a slow onset, is going to be more cases where it's maybe someone was switching from one antidepressant medication to another, but they didn't give a long enough period for the levels of the first drug to wear off, or if it was more of like a tyramine like reaction. More often than not, I would see this as a result of overdose, typically, where patients have taken too many medications that all interact with serotonin, and that led to that pretty rapidly within a couple of hours or so. But serotonin, St. John's wort is a dietary supplement people may use for more mild cases of depression, maybe because it acts sort of like a monoamine oxidase inhibitor to some degree, and can also block some reuptake of things like serotonin. The reason why this is very notable is because some people may want to use a more natural supplement or more natural product to treat their depression. And there's nothing wrong with that, because certainly St. John's wort can be effective for more mild to moderate cases of depression. The big thing to note, though, is that if they're going to be taking this, like, they need to know not to take it with any other prescription-based products for depression, because they will interact and can lead to risk for things like serotonin syndrome. So make sure you ask your patients, are you taking anything? Are you interested in taking anything like this? Because if they are, then you don't want to be giving them something like citalopram on top of that, right? Other notable things as well is the fact that this St. John's wort can act as a 3A4 and P-glycoprotein inducer. This means that it can lead to decreased levels of many other medications. So if you had someone taking simvastatin, it's going to lead to lower levels of that simvastatin, right? If they were taking something like amlodipine, it's going to lead to lower levels of that amlodipine. It may not be as effective. So those are the big things to watch out for. Again, I have nothing against dietary supplements at all. They can be effective for some things, but you need to be, the patients need to be, you have to ask about it, because if they don't tell you about it, then they may be taking it. That can lead to some a lot of side effects that you may not be aware of, right? So that's why I think it's important to at least have that conversation with them and be open and honest about it. It can be effective. It may not be the most effective thing, but if they want to try it, nothing wrong with that, right? So generally speaking, you want to start off with an SSRI or a newer agent. I'd probably, if they had a history of like, some sort of, neuropathic pain issue, start off with an SNRI, right? You get a little bit of double duty being treated there. But if otherwise they're otherwise healthy, an SSRI might be a really good first stop for those patients there. I probably wouldn't use a TCA unless you really needed to, unless they had a really compelling reason, just due to the adverse effect profile. And then MAOIs would really be a last resort. Again, I didn't really talk about them here just because it's so uncommon you find a patient that actually require that. So that's it for the section on depression here. I don't really have enough time to get into bipolar disorder, so I think I'm going to go ahead and finish a little early today. Hopefully you guys don't mind. But if you have questions, let me know. I'll stay on for a few minutes for sure. There's a neurology quiz this week, so if you can take that, give you some practice for what some question on the test might look like, for instance. And then your prescription assignment will be due I think on the 12th is what I set it for. Yeah, so all your feedback is back for that. Biggest things is just make sure you're looking at the rubric, making sure you're addressing everything. Make sure everything has a frequency. Make sure everything has specific. The other things that were there. Frequency is probably one of the biggest things, just being very clear about that, making sure that if you say something is PRN, like saying what is PRN for, those are really the big issues I ran into from feedback from what I can remember. But yeah, so otherwise, I hope you guys have a good rest of your week, and I'll see you guys next time. I don't see any questions on the board, so I think I'm going to go ahead and end it here. Yeah, thank you. Have a great day, and I'll see you guys next time.